Our final chapter for this unit is carrier screening, or chapter 13. And this is when we analyze chromosomes, DNA, RNA, proteins, or any other analyte to detect an abnormality that may cause a genetic disease in one's children. So now we're talking about people who are unaffected themselves, but they have one copy of a mutated gene. Population screening is really what we do. We test for treatable diseases before they have any symptoms, for a pre-symptomatic phase. So this carrier screening really is population screening for things like hypercholesterolemia or pap smears. And population screening is a large-scale testing of populations for a disease, again, in an effort to identify those who are well, who probably have a disease, from those who probably do not. Okay, but in the case of carrier screening, they are well, but they're concerned about their children. So we're looking for a subset of the population on whom further testing should be performed. Screening programs themselves are use tests that can be applied. They have to be inexpensive, and they got to test at-risk individuals. So once you do the at-risk, then you do additional testing if they have a positive. And those tests are more accurate, expensive, and time-consuming, but it confirms. Now, again, we have to talk about something your textbook doesn't mention a little bit, but getting the right test is very important. So these tests have to be valid. In other words, they've got to separate normal from affected individuals. And in order to be valid, they have to be sensitive. Are they correctly identifying those with the disease? So this is measured as the proportion of affected individuals in whom the test is positive. True positives. So that's sensitivity. Specificity correctly identifies those without the disease. So they're measuring the true negatives. So a valid test has to be sensitive, identify those that are positive, and specific, identify those that are negative. And sensitivity and specificity are determined by comparing the screening results with a definitive diagnostic test. And I just thought I'd throw this in so you feel a little like you can talk about all this with your friends and family and physicians and stuff like that. Well, I know all of it. Of course you do. So, again, this is not in the textbook, but I thought I'd go through this very quickly. Principles of screening. When deciding whether population screening is appropriate, one should know disease characteristics. The disease should be serious and fairly common, so the benefits will justify the costs. You have to understand the natural history of this disorder in order to do this. There's got to be an acceptable and effective treatment and prenatal diagnosis if necessary. Test characteristics, again, acceptable to the population. It's got to be something that, is not going to harm them in order to go through the test, okay? It's got to be easy to perform. We would love it to be inexpensive. And then, of course, valid and reliable. And finally, the system characteristics. The resources for diagnosis and treatment must be accessible, and strategy for communicating the results and counseling should be in place as well. So this is, again, from an earlier textbook. The rest of the slides are actually from our textbook. But it's the same thing, showing you genetic defects that are newborn screening, the ones that are done in all 50 states just about. Heterozygote screening, we're going to be talking about the Ashkenazi Jewish population. And, of course, here's the prenatal diagnosis and population screening and family screening as well. So what we're really talking about is heterozygote testing. We're detecting unaffected carriers of disease-causing mutations. Our target population has to be a group that's known to be at risk. Intervention consists of a presentation of risk figures and options, such as prenatal diagnosis. It works well for autosomal recessive disorders for which there is prenatal diagnosis and genetic counseling, and this includes Tay-Sachs beta thalassemia major and cystic fibrosis. And here are public policy guidelines for heterozygote screening. Should be voluntary, confidential, the results, requires informed consent, quality control. There should be equal access to testing. And here's your textbook's version of these things. Major disorder subject to carrier screening, the test. Sometimes it's not DNA. And then the carrier frequency. So we're going for a pre-symptomatic diagnosis. So we only want to test individuals known to be at risk. All right? And we want to get them before the symptoms develop. Ones that are really useful that way is Huntington disease, although that's a really nasty disease to know that you're coming down with. But it usually doesn't present until the age 40. Adult polycystic kidney diseases as well. Hemochromatosis and autosomal dominant, of course, breast cancer. Purpose? Reproductive decisions, reassurance, early diagnosis, can also help with health supervision. And these are some of these other things that we can do. If they had a familial adenomatous polyposis, they can have early colonoscopies and removal of the polyps, the breast cancer, early mammography, etc. So we get into our case. And we're going to talk about a young couple, Ruth and Ted. They're newlyweds. They're both of Ashkenazi Jewish ancestry. And so their synagogue, of course, recommends that they get tested for Jewish genetic diseases. And a number of genetic diseases occur more frequently in certain ethnic populations. Now, this is some information. Of course, I'm sitting here working on this, and I go, well, you know, I never really. I knew there was a founder effect in the Ashkenazi Jews. Your textbook says something about it occurring at the 1500s. I thought, well, I'm going to take a little bit more of a look into this. So we know that the Ashkenazi Jewish population is, of course, from Eastern European descent, usually around the Rhine Valley in Germany. And it has been estimated that 1 in 4 individuals is a carrier of one of several genetic conditions if they're Ashkenazim, let's put it that way. The diseases, and there are quite a few diseases. In fact, they're actually tested for 19, some other places recommend about 21. But Tay-Sachs disease, Canavan, Niemann-Pick, Gaucher, I finally found the right way to pronounce it, familial dysautonomia, Bloom syndrome, Fanconi anemia, cystic fibrosis, and mucolipidosis 4. And this is all from something called the Jewish Virtual Library, which is actually a consortium of American-Israeli personnel. It's actually kind of fascinating, so if you like history and things like that. Well, it was just recently, in last September, that an international team of scientists announced that all Ashkenazi Jews descended from about 350 individuals, so only 350 of them, who lived between 600 and 800 years ago. That's amazing. They were obviously of Middle Eastern and European descent. What they did was they compared the DNA of 128 Ashkenazi Jews with DNA of a reference group of 26 Flemish and worked out which genetic markers are unique to the Ashkenazim. And what they found was similarities in the Ashkenazi genomes allowed scientists to identify a base point from which all of them seem to have been descended. And so after they did some calculations, they realized that this makes all modern Ashkenazi Jews 30th cousins. So they have a much higher risk of being a carrier and transmitting a mutated gene. So why bother to do this? Because now doctors have a better idea where to sequence an individual's genome to test for disease susceptibility, because they identified these genetic markers that are unique to the Ashkenazim. What if it's someone who doesn't know their background or anything like that? We can test for this now. We'll be doing this more and more for different races, and this is what it's going to help us understand. So that gets us to something called Tay-Sachs. There are 3 forms of it. It's a nasty disease. There's the acute infantile, which is really bad. It develops in the first 3 months, death by 2 to 4 years of age. The juvenile occurs between 2 to 10 years, death by 15. And then you have the chronic adult onset. This can be very variable. It can be mild. You can go up to muscle wasting, leading to dementia. So it's not a nice disease. What's going on? Well, it turns out it's another one of those lysosomal storage disorders, which we talked a little bit about in Chapter 11. This one, they're missing one enzyme. It's called hexosaminidase A, or HEX-A. And unfortunately, if you don't have this, you can't break down GM2 gangliosides in your neurons. These obviously need to be broken down in your neurons. And so they accumulate. And as a result, this is going to cause swelling in the cells. It's going to be toxic to the cells, and you begin to lose neurons. Now, the nice thing is we can test for the enzymatic activity in plasma or peripheral blood leukocytes, and it actually is a lot more useful to test for that because, again, there are going to be a lot of different mutations, and one particular DNA test may not screen for all of them. And we find that the levels of the HEX-A really do correlate with the different forms, the acute, juvenile, and chronic adult. Well, carrier testing actually started some time ago for Tay-Sachs because it was so devastating with the infantile. And worldwide, before the testing started, it wasn't that common, maybe 60 cases a year, but the child always died. It was the acute infantile. Now it drops down to 3 to 5 a year worldwide. So it's worth it. And cloning of the gene helps to identify the mutations. The major ones that we see are frame shift and a splice site. This is the sort of thing I want, again, in your rewrites of your discussions. So, okay, so they go to Ruth is going to go to the gynecologist, and then Ted and Ruth are going to go see the genetic counselor. Ruth's given a clean bill of health by the gynecologist and says, well, yeah, but you are an Ashkenazi Jew, you should see the genetic counselor. Ruth talks to Ted, and he goes, yeah, it makes sense, let's make the appointment. And however, before meeting with the genetic counselor, they probably got a packet in the mail, and you got to go talk to your relatives and ask them all these questions so that the counselor can actually make a pedigree. And in future versions of this course, I will be adding the activity of a pedigree. But unfortunately, I didn't have time to do this now. But you can go online and get information and see if you can figure these things out. Because you may have situations, depending on where you work with, that it could be helpful for you to try to explain some of these things to your patient. So they get the family history based on this. When they go to their appointment, the counselor forms a pedigree that does not show really any history of disease. So they feel good about that. But you can't really know until you get your blood drawn. So they draw the blood, and both Ruth and Ted are tested for 19 disorders. And here are the 19 disorders that they're tested for. Bloom, Canavan, now of course they're in alphabetical order. Usher's, Walker-Warburg, all of these are classic. And what I want to point out, though, is I want you to take a look at Gaucher. Or, no, I'm sorry. This is familial dysautonomia, 1 in 30. That's a real high frequency, a carrier frequency. Some of the others, 1 in 40, 1 in 14. This is what I meant, Gaucher. 1 in 14. That's amazing. Not good, but it is amazing. While Ruth and Ted find out about the results, we'll talk about population screening for the hemoglobinopathies, which are also commonly screened for. Normal adult hemoglobin, or hemoglobin A, is a tetramer, has 2 alpha and 2 beta chains. Sickle cell anemia is one of the things that we screen for. It's caused by a single missense mutation in the beta chain. We also screen for the thalassemias. These are defined as a deficient production of either alpha or beta chain. So we got beta thalassemia. We see these more in Mediterraneans, and different types of mutations can lead to this. And then alpha thalassemias The alpha chain, we actually have 4 genes. That's a duplication. So you get 2 from mom and 2 from dad, so you end up with 4. So to get the really, what we call alpha thalassemia, minor and major, the major is really nasty, but you have 3 genes that have been affected for major and minor. And the major alpha thalassemias are usually not compatible with life. So again, just like with the screening programs for something like Tay-Sachs, it's reduced the incidence significantly. And again, it doesn't use DNA testing. I actually used to do some of the screening for this when I worked in clinical labs, and used to get the blood and separate. You'd isolate, you'd lyse open the red blood cells, and you'd run a gel electrophoresis and look for different patterns of migration reflecting different beta hemoglobins or alpha hemoglobins. And that's a lot more valid than the DNA screening in many ways, because sometimes you don't pick up what the mutation is. All right, so there's also population screening for cystic fibrosis. Now here's an example again of one with lots of different mutations, more than 1,500. And this is a very large gene. It's a cystic fibrosis transmembrane regulator gene, and it's controlling the transport of chlorine, or I shouldn't say chlorine, chloride ion. And again, it's a very, very large gene. We screen typically for the 25 most common mutations, which detect 98% of carriers of European descent, slightly lower for the African Americans and Hispanics. American College of Medical Genetics and American College of Obstetricians and Gynecologists recommend offering testing to couples planning a family. We're looking for, of course, couples in which both are carriers, and if both parents are carriers, they offer prenatal diagnosis. And this is just showing you some of the splice site mutations and stuff. I'm not going to test you on it. If you're interested in this, you could take a look. So let's see what happens after the testing. Ruth and Ted return to the clinic and find out they are both carriers for Tay-Sachs. Ruth has the insertion mutation that is common. Ted has the splice site mutation. Ted finds out he's also a carrier for Gaucher. Not surprising, 1 of 14, but Ruth is not. So there's no risk for them of having an affected child with Gaucher. Ted, however, it turns out that carriers for Gaucher seems to have a higher risk of having symptoms of Parkinson's disease as he gets older. So they have a 25% risk of having a child with Tay-Sachs, and that can be pretty scary. But of course they're going to have to tell this to their family too, and the family should be getting tested. But when Ruth does get pregnant at 18 weeks, because they know about this, they have the amniocentesis and they find out the child is normal. Well, of course they're excited, and things are going to be great. Families get tested, and what do they find? Well, Ruth's sister also tests positive as a carrier for Tay-Sachs, and Ted's brother is also a carrier for Gaucher. So they all now are aware of it, and of course that will make prenatal diagnosis. This will make it easier for them to deal with the situation should they have an affected child. So let's talk about the Tay-Sachs a little bit. Again, it's a lipid storage disorder. Gradual accumulation leads to multi-organ dysfunction. This is the same thing about Gaucher disease that we saw in Chapter 11, so I'm not going to go through it again. But it's the most common of the ones that we see in the Ashkenazim. Their symptoms, again, can be visceral megaly, multi-organ failure, and again, a debilitating skeletal disease. Type 1 is most common. The central nervous system is not affected. Type 2, the most severe, death by 2 years. And type 3, intermediate. Again, lots of different types of mutation in the gene. That's GBA. And the nice thing is, though, that this can be treated. Enzyme replacement works really well for the splenomegaly and the hepatomegaly that they typically see. And the bone marrow transplant has been successful in some of the more severe cases. However, the features of Parkinson's seen in Gaucher carriers of type 1 is still something that they have to deal with as those carriers get older. Well, I'm sure you're aware there's going to be a lot of psychosocial implications of a genetic diagnosis. And there are many: anxiety, the stigmatization of a positive test, the burden of cost. Screening tests can be misperceived as diagnostic. This is a result of 1970 screening for sickle cell anemia. This was really nasty. My husband had a good friend when we met at Marquette University. I went there as an undergrad, and as many of us who go to college, we meet our spouses there. Sometimes it sticks, sometimes it doesn't. I was lucky. But anyway, he had a friend who was told he had sickle cell trait. He was a carrier. And he really misunderstood his carrier status. He felt he should never get married, and he was afraid of flying, and all this other stuff. And once health insurances found out about this, they started canceling. Employers discriminated against them, and they fought for right not to be tested, and I can't say I blame them. In the UK, they found few at-risk individuals want to get tested for Huntington and breast cancer. There's no effective treatment. The cost of the test is a lot, and surgery is not 100% effective. So in some cases, they don't want to know. I don't know. I think I might want to know if it's in the family. But for some disorders, early diagnosis can lead to improved survival, colon cancer syndromes, hemochromatosis. So, yeah, I think if there was something like that in my family, I think I'd have to go and find out. Now, before I finish this lecture, I should warn you that there are limitations to genetic testing. No test is 100% accurate. And that's because there are mosaicisms, there can be genotyping errors in the laboratory. Just because someone has a mutation, as we found out in an earlier case study, it doesn't necessarily mean that there's going to be disease, reduced penetrance, things like that. And mutation tells little about the age of onset or how severe it's going to be. We may not detect all of the mutations that can cause a disease. That's another problem. There may be too many different mutations. This is definitely true with cystic fibrosis. And in those cases, linkage analysis may actually be better. And of course, again, it leads to those complex ethical and social considerations. So I have to admit, I think this unit is one of the more interesting ones, particularly because we get into the developmental testing and then this early testing to help couples and to help newborns. And of course, if you're from the Milwaukee area, you know that last year the journal Sentinel did a big thing on genetic testing and the efficacy of reporting, how quickly they were reporting the results, and of course that has a be a major factor in preventing disease symptoms with some of these inborn errors of metabolism. So that's it for this particular unit. We just got 2 more, and I will say goodbye, and I'll be talking to you soon.